Today, CCR is decided to go to medical oncology department. It's very interesting case, chemistry within the node, presented by Dr. Atul Batra. And further discussion to be taken care by podium and other faculty. Dr. Atul Batra.
Thank you, sir. On the behalf of Department of Medical Oncology, I would like to thank you all for coming for today's case. We know that breast cancer has now become the most common cancer in India as well as globally. Out of 14 lakh cases of total cancer, new cancer cases in India, 2 lakhs, more than 2 lakhs are actually due to breast cancer. So this was an interesting case. Although we see around more than 2,000 cases per year of breast cancer in AIIMS, we haven't encountered this over the last 20 years. And this was the first case that we saw here. Overall, also, there are very, very limited cases that have been reported here. So today we would, Dr. Shubham would take on the history and presentation of this case, and discussion would be done by Dr. Shubham. Thank you.
Thank you, sir. Very good afternoon to one and all present. So this case is titled "The Mystery Within the Node." So this case is of Mrs. KS. She's a 66-year-old post-menopausal female homemaker, resident of Uttar Pradesh, and she denied any comorbidities or addictions. She presented to us the following chief complaints. First, of a painless lump in the left breast over the past 1 month, associated with retraction of the left nipple for the last 1 month, and some generalized fatigue which was non-specific over the past 1 month. She attained menarche at the age of 15 years and attained menopause at the age of 58 years. She is postmenopausal at present. Her prior menstrual cycles were regular with normal flow and she denied any dysmenorrhea. She is married, however, she is nulliparous. A detailed family history did not reveal any history suggestive of malignancy or premature deaths in any of the family members. And we can see our patient here, and she is nulliparous. On examination, she had an ECOG performance status of 2. Vitals and other general physical examination aspects were non-contributory. Systemic examination was within normal limits, and there was no abnormality found. However, the breast examination revealed a solitary hard lump around 3 cross 3 centimeters in the left breast at 12 o'clock position near the nipple areola complex, and the overlying skin was free, the underlying muscle was not involved, and the left nipple was also retracted. In addition, we also found a single discrete mobile axillary lymph node in the left axilla as well. So overall, this case, like any other routine case in the OPD, looked like clinically T2N1 carcinoma left breast. A mammography was done by the patient outside, and we can see that there is an ill-defined, irregular, heterogeneously hypoechoic lesion, which was on ultrasound. And on mammo, we can see it was around 3 cross 2.2 cross 2 centimeters with partly spiculated margins located in the retroareolar location. And it was Byrat's 4C lesion. The left breast was normal. Now, this Byrat's 4C lesion prompted us to do a true cut biopsy from the left breast lump, which was compatible with the diagnosis of an invasive breast carcinoma of no special type. It was MNBR grade 2. There was no ductal carcinoma in situ component present. The estrogen receptor was positive with an Aldrich score of 8 by 8. Progesterone receptor was also positive with an Aldrich score of 6 by 8. And HER2 was negative with a score of 1 plus. Ki-67 labeling index was 10% in the highest proliferating areas. So prior to presentation at IRCH, this patient had already underwent an FTG PET CT, which did not reveal any evidence of distant metastasis. However, there was no, we noted an isolated paracaval node about a centimeter in size, which was of doubtful and equivocal significance. So the overall impression was one of a postmenopausal carcinoma left breast, clinically T2N1M0, invasive breast carcinoma of no special type, hormone receptor positive and HER2 negative. So just like the routine management of an early hormone receptor positive breast cancer, she underwent upfront left modified radical mastectomy at surgical oncology department at IRCH on 9th of May. And the post-op histopathology, and for discussing the post-op histopathology report, I would like to invite Dr. Shivangi from the Department of Pathology to take the discussion forward.
Good afternoon, everyone. I am presenting the pathology part of the case. So first we received the core biopsy from the breast mass and 5 cores of breast tissue were received and it showed invasive breast carcinoma, no special type, grade 2. It was, as discussed by Dr. Shubham, ERPR positive, HER2 negative, KI was low around 10%. Then, post-op, we received the modified radical mastectomy specimen of the patient, and multifocal tumor was found in the same quadrant. On the histopath of the tumor, it showed features compatible with the biopsy diagnosis of invasive breast carcinoma, NST grade 2. And axillary lymph node dissection yielded 25 lymph nodes. So this is a histo picture of the nodes. So here we can see that this nodal architecture is distorted by some glandular formation and atypical cells, while we can see the normal nodal tissue around it. So 3 out of these 25 nodes showed metastatic tumor deposits. While this morphology looks different from this, and it shows more of a sheet of similar looking cells effacing the lymph nodal architecture. So all the nodes showed this diffuse effacement of the architecture by these intermediate sized atypical, possibly lymphoids. So this was an unexpected histopathology finding of the case and which needed to be worked further and was hence worked up. So this is a high view of the same. So here we can clearly see that these are glands infiltrating in the nodal parenchyma, which is compatible with metastasis from breast primary. This looks very different from this and is completely effacing the nodal architecture with these intermediate to large size atypical cells. So possibility of coexisting lymphoma was thought. So pancytokeratin, which is a marker of epithelial differentiation, was performed. You can see in the area which was considered to be mets, it has come positive in the metastasis, while in the suspected lymphoma area, it's negative. Then to further type the lymphoma and confirm the presence of lymphoma, CD3 and 20 were done. And we can see they are diffusely positive for CD20, but the surrounding the CD3 cells are there. So it was a B lineage non-Hodgkin lymphoma. Then, based on morphology, it looked like a diffuse large B cell lymphoma since it had intermediate to large size atypical cells. So further typing of the lymphoma was performed. And see all the markers CD10, BCL6, CMYC, BCL2 and even MAMA were negative and it was considered to be DLBCL post-germinal center type. So final diagnosis on pathological findings was made as multifocal invasive breast carcinoma, no special type, with metastasis to axillary lymph nodes with extranodal extension, along with concurrent non-Hodgkin lymphoma, that is the diffuse large B-cell lymphoma post-germinal center type. So now I'd like to call my colleague from nuclear medicine for further discussion.
Good afternoon, everyone. I'll be discussing the FDG PET-CT of this patient. This is a 18 of FDG PET scan done on 18th April 2025. Here, this is a maximum intensity projection image. Here, we could see the physiological uptake in brain, then liver, spleen, and the kidney. This is a fused PET-CT images which shows FDG with few irregular soft tissue density lesion in the left breast. Also, in this image, we could see there are few FDG with left axillary level on lymph nodes. The unusual finding in this case is the retrocaval lymph node, which is seen here. This is just a urinary activity, which is normal. This is the FDG with retrocaval lymph node, which is very unusual in this case. Usually, breast carcinoma, it is very rare for a breast carcinoma to metastasis to retrocaval region. So although in cancer anything is possible, so the possible DB will give us like metastasis, lymphoma, and granular metastasis. This is the follow-up PET scan which done after 2 months on 23 June 2025 after the histopathological diagnosis is made. This is again the maximum intensity projection image. Here we could see there are multiple hotspots in these images. So here we see the multiple FDG-avid lymph nodes in the cervical, axillary, mediastinal. Here we could see the chain of lymph nodes in abdominal and pelvic region. Also, we see here there is an intense FDG uptake in the spleen. Also, in this image, we could see there are a few patchy FDG uptake in the bone marrows. So, since it's already DLBCL diagnosis is made, so this would go to the stage 4 DLBCL. Here we could see this was the previous baseline image, which shows very few hotspots here, the breast lesions and the axillary lymph nodes. And this is the follow-up image after 2 months. So this is showing the multiple hotspots like supra and infradiaphragmatic lymph. Thank you.
Thank you, Dr. Sanjeev and Dr. Shimangi. So this was a scan which was done when the patient presented to ISH. The patient had the scan done before itself. And since post-MRL, we got the diagnosis of a lymphoma, and it had been 2 months since diagnosis of a lymphoma without treatment. We planned to do another PET as well, which actually revealed a stage 4 disease at this time. So the final impression was one of carcinoma left breast, hormone receptor positive, HER2 negative, which was stage 2B, multifocal pathological stage, as was told, was T2N1A, clinically M0, along with a surprise in hand, which was diffuse large B-cell lymphoma, non-germinal center subtype, which was stage 4, with an international prognostic index of 3/5 and a CNS IPI of 3/6. Perhaps these two tumors collided in the axilla, and we can call them a collision tumor. CBC did not reveal any cytopenias, and there was no evidence of tumor lysis syndrome at this time as well. Now, we had a conundrum in mind. We had to treat this patient for diffuse large B-cell lymphoma, which is curative. We also had to treat this patient for a stage 2 carcinoma breast, and we needed to push in chemotherapy and radiotherapy for that. At the same time, since she's 66-year-old, we had to minimize toxicity and perhaps achieve cure for this patient. So the management of stage 4 DLBCL is straightforward. It is 6 cycles of R-CHOP, which is rituximab, cyclophosphamide, adriamycin, vincristine, and prednisolone. And the management of stage 2B carcinoma breast, which is hormone receptor positive, would entail surgery followed by adjuvant chemotherapy since she was node positive, with 4 cycles of dose-dense adriamycin plus cyclophosphamide, which remember also comes in the R-CHOP backbone, followed by 4 cycles of dose-dense taxanes, followed by endocrine therapy for a duration of 5 to 7 years. Along with this, she would also require an adjuvant radiotherapy to the chest wall and the supraclavicular fossa, and an additional axillary radiation given the extranodal extension, as was told by Dr. Shivangi. A genome expression profiling was also offered to the patient. However, it could not be done due to financial issues, and a germline testing also couldn't be done. So the management plan that we have made for this patient is 6 cycles of R-CHOP chemotherapy, which will cover for the 4 cycles of anthracycline plus cyclophosphamide, which is required for CA breast as well, and would perhaps be curative for stage 4 DLBCL. We would reassess this patient for taxanes because both vincristine as well as taxanes have a risk of cumulative neuropathy. So we'll reassess the patient again for eligibility for taxanes. This shall be followed by radiotherapy to the chest wall, axilla, as well as the supraclavicular fossa, axillary RT given the extranodal extension, followed by adjuvant anastrozole for a duration of 5 to 7 years, plus minus ribociclib as per the NATALEE trial. And this would perhaps be curative for stage 2B hormone receptor positive CA breast. So this is our management plan, and now I would like to call upon Dr. Chitrakshi to take the discussion forward.
Very good afternoon, everyone. Thank you, Dr. Shubham, for taking us through the journey of this patient from a straightforward diagnosis of CA breast to a collision tumor with CA breast and DLBCL. So, coming to the topic of multiple primary malignancies or a second primary malignancy, multiple primary tumors in the same person have been defined since the 1800s. In 1932, Warren and Gate definition of multiple primary tumors had come around, which involved that both the tumors must be definitely malignant on the histopathology. The second tumor must be separate from the index tumor. The second tumor must not be a metastatic lesion, so histopathologically different diagnoses must be made. So these would be divided into synchronous or metachronous tumors, which by definition would be something that presents within 6 months of the primary tumor is called synchronous, and something that comes beyond 6 months would be metapneumosis. It is more common in females as well as more common in patients with older age, primarily because the patient is living long enough to develop a second primary tumor. So commonly the second primary tumor that we would see by virtue of same risk factors would be a patient who has head and neck primary, presents with a second primary in the lung, with a second primary in another site in head and neck, or with a second primary in the esophagus because of the shared risk factor smoking. A patient with CA prostate would commonly present with CRC or CA urinary bladder. A breast cancer patient would present with breast or endometrial carcinoma, and uterine and ovarian malignancies might coexist both by virtue of them having risk factors like hormonal status, like age, as well as genetic predisposition. So, why the second primary tumor would develop in one individual? Primarily because of shared risk factors. For example, a patient who is infected with human papillomavirus might present with CAPNS, with anal cancer, as well as with oral malignancies. A patient who has a genetic predisposition like hereditary breast and ovarian cancers or Lee-Perman syndrome, etc., or environmental factors might also predispose to the same. So this is a 25-year experience from a primary center where they found that patients with CA breast, with head and neck cancers, with colorectal cancers, and with liver cancers are the primary tumors with which a second primary tumor is more commonly seen. So why would a patient with breast cancer have a high risk of getting a second primary? Generally speaking, the incidence of having second primary malignancies is also increased because there are better survival rates in cancer patients. So a cancer survivor who is living for a longer time is getting more time to actually develop the second primary tumor. Additionally, we also have better detection techniques, better screening methods, and better diagnostic techniques. And we do have the shared risk factors that I just talked about. Apart from that, specifically for breast cancer, since it is the most prevalent disease per se, we are bound to see more number of patients with the second primary tumor as well. So the most common cancers seen in breast would be 60 to 70% of them would primarily present with a contralateral breast cancer itself. Apart from this, we can have ovarian, endometrial, cervical, colorectal, thyroid, RCC, and pancreatic cancers. However, for our patient, this was not the case. We did not see something that would commonly be expected in such patients. We saw a patient who had both breast as well as DLBCL in the same lymph node. So there is a term for these tumors called collision tumor. So these are two or more distinct tumor types which maintain distinct boundaries, however, they will coexist at the same anatomical location. So these are usually incidentally diagnosed on histopathology. They are very rare, but it is very well documented. And they have various theories why someone would develop this collision tumor. So initially, the most commonly accepted theory was that it was just a chance event. Two distinct clones were there of neoplastic cells, and they independently just came in close proximity to each other. After that, we thought that maybe it is field cancerization which is causing it. So there is recurrent damage, for example, in xeroderma pigmentosum, and we can see an STC, a basal cell carcinoma, and a melanoma at the same site. But the most widely accepted theory now is that of an interaction theory, where one neoplasm is producing some factors which is causing stromal or epidermal changes, and via this paracrine effect, it is causing the development of a second primary in the same lesion. So there are some reported cases of collision tumors with breast cancer. Primarily, the largest case series is with CLL, where 7 patients were found to have CLL and breast cancer coexisted. Apart from that, as we can see, this was the first collision tumor that was reported in 1966, where they found a lymphomatous tumor as well as ductal carcinoma in the same lymph node. Since then, we have had a case with follicular lymphoma, and we can clearly see the margin in the photo. We also have seen a case of invasive ductal carcinoma with mucosa-associated lymphoid tissue, as can be seen in this picture. Then we can see this case series of 7 patients of CLL having a collision tumor with CA breast. Recently, another case report was published where they also saw plasma cell myeloma along with CA breast in the same bone marrow biopsy. So the likely pathogenesis of our case could be because of an ATM gene or some HRR gene mutation which predisposes to both these malignancies. EBV virus has been associated with CA breast as well as positive 10 to 15% of DLBCL. The breast cancer spreading into the axilla might cause antigenic stimulation into the axillary lymph nodes and cause proliferation of the lymphoid tissue. And lymphoma causing immunosuppression may also stimulate the proliferation of CA breast. Or, as we say, it could just be a translocalization as well. So, coming to the management of collision tumors or secondary primary malignancies per se, the management is driven by the tumor which will drive the prognosis of the patient. So, if both the tumors need systemic therapy, we have to find a regime that is effective against both the primaries, but we need to take care of the aggressive tumor first. And we need to make sure that if we are combining chemotherapies, there is no increase in toxicity and there is no reduction in the outcomes. So, the rule of thumb says we hit the aggressive tumor first. So coming to DLBCL stage 4, this was activated germinal center stage 4 DLBCL. R-CHOP has stayed the test of time. It has been the standard of choice for the last 2 to 3 decades. However, recently there has been a trial of R-polatuzumab vedotin along with CHD in patients who have activated germinal center and who have an IPI of more than 1 and who are older than 60 years. These patients have shown benefit in this subset. So we treated the patient with 6 cycles of R-CHOP and we plan to get an interim PET after the third one. Coming to the management of stage 2B CA breast has been discussed by Dr. Shubham. Just wanted to bring about the options that we have for these patients. So these patients could also be treated with 6 cycles of docetaxel and cyclophosphamide. We could give 4 cycles of anthracycline cyclophosphamide followed by 4 cycles of taxane. And in this patient, since we are giving 6 cycles of R-CHOP, although there is 5% DFS and 3% overall survival benefit with addition of taxane, probably when we are giving 6 cycles of anthracycline instead of 4, we could omit taxane if the patient's tolerance is an issue. So where are we right now with our patient? The patient's surgery is done. She has received 3 cycles of R-CHOP and is awaited. If the patient has a very good tolerance and she has not developed any significant neuropathy, we will consider giving her 4 cycles of paclitaxel followed by endocrine therapy. Along with that, we would also give local RT, which would cover the axillary level 1 to 3 as well as the supraclavicular lymph node, which would also work for DLBCL as well. So coming to the prognosis, generally collision tumors have an aggressive course and the prognosis is dismal compared to either of the counterpart. As a rule, more the time between the development of the second primary to the index tumor, better the prognosis. So a patient who is presenting with simultaneous DLBCL and CA breast might not do as well as someone who had a metaclonus tumor. If we use the predict score, we can see in patients who have, in this particular patient where we put her Ki67 and her size of the tumor, we found that for 10 years her survival is around 75%, with chemotherapy improving survival by 6%. And if we see DLBCL stage 4 with an IPI of 3, a 4-year overall survival of 55% is seen. So this patient's survival will be driven by the DLBCL treatment. So that's why we plan to give her 6 cycles of R-CHOP and then we would see if we can give her taxanes or not. I would like to thank the Department of Pathology, Department of Nuclear Medicine, Surgical Oncology, Radiation Oncology and Radiodiagnosis. And I would like to call Dr. Atul Batra sir for the concluding.
Thank you, Shubham and Chakravarti, for taking us through the journey of this patient. So this was a learning experience for us as well. We have not encountered a collision tumor with CA breast earlier, and this was the first case that we saw. So if we now go back and look, there were certain subtle clues that were kind of not seen there because that's not done routinely. So when this PET scan came earlier, we saw that there was a paraiotic node, but that wasn't even reported. When we discussed it here, it was too small to do anything. But now we can be wiser that there was something, probably something could have been done. And by that time, within 2 months, we can see the aggressiveness of DLBCL that it had now gone throughout all the lymph nodes as well as bone marrow involvement. Good thing is still the patient has two malignancies, but both of them are curable and treatable and curable. She has a reasonable chance of being cured from both the malignancies, although her treatment would entail a lot of kind of multimodality management. She's undergone surgery, she would undergo a lot of chemotherapy and then radiation and then hormonal therapy. Let's hope for the best that she could be cured, that's what's our hope. And this is one thing that we learned from this case, a new terminology, collision tumor. It's not new, it was coined a little earlier, but for us it's new with this case. Thank you so much for your kind attention. We're open to take any questions. There are several tumors with breast. So if a patient has a germline mutation when BRCA1 or 2, that could be ovarian malignancy, which could be synchronous or metachronous. We have seen patients with DLBCL, but they would come later at different time points. These patients can also develop therapy-related leukemia because they're getting anthracyclines. They can get AMLs and ALLs later on in the course of life. Since breast cancer is the most common cancer as such, and it's treatable, curable, they go on to live till 30, 40 years more. So they are exposed to all other things. See, endometrium has shared risk factors. We've seen that as well. We've seen one with tonsil. I mean, that we talk about the cancer and we have seen all those things. Thyroid would be common, yeah. Thyroid is probably, we don't know till now. We can say that till now we don't know what's happening, but yeah. We don't know what the baseline radiation is doing, which exposes to both the cancers. So, could be.
Very surprising, and when we saw the lymph node, the DLBCL part of it was not very apparent at first look. It was just a diffuse architecture, and with nets coming up, we were not very sure because this was the first time even I was seeing it. But then the IMCs and everything helped us. So the morphology was also, when we got back to it, and all the lymph nodes were showing similar diffuse architecture. It was a good case of learning for us.
That's why Dr. Atul has to be your department. Now, without pathology, of course, this diagnosis wouldn't have been possible at that time point, but would have come later within a few weeks for sure with other B symptoms and all.
For nuclear medicine, like when we follow up PET scan, so how can we decide whether these are metastatic point of DLBCL or the metastatic?
So I'll interject and say again, we take help of pathology, and it's a dictum that you do a biopsy. If you see a
You'll be so sure that whether it is DLBCL or the 2-week MI you show, should that be a metastatic breast cancer? Would that change the diagnosis? I mean, the management, they might give me more aggressive. I mean, how do you define, how do you differentiate?
there are features on the basis of the application.
So,
on the basis of the feature of the tumor, on the basis of that, we can say this is because of the breast cancer. And as for the nodes are difficult to differentiate between whether this is because of the breast or this is because of the lymphoma. We can see on the basis of that area of distribution. Like in breast cancer, and in this case, we have seen a retrograde paracleval lymph node in the ground, which is not a site of the breast metastasis. We say that's why we have the given the definition that it can be because of other pathology. So on the basis of the distribution of the node, on the basis of on the basis of other features, we can say this is because of the breast or this is because of the lymph. Good part is that we will do the MD nuclear medicine.
Another point would be that if you see this was an ER positive with a P67 of 10%, that's a slow growing tumor. And this pattern within 2 months having throughout this thing, that would add that it is because of it. In the same mode, we had an RCC with CLL recently. But within the same node, having a distinct border and all.
Out of curiosity, one question is there. Suppose these patients have been triple negative.
Triple negative.
You told that aggressive disease to be treated fast, then how will you do? Any
So
consistency?
we would also like to biopsy, of course, from the site that we feel is accessible. We would do a repeat biopsy. I mean, based on PET scan, and sorry, Dr. Nami, but pathology remains the gold standard. We can just assume and take a good guess what it is, but ultimately we'll need pathologists to have a look at what's there.
Both the things are aggressive. Then how will you decide between chemotherapy?
So, if this was a triple negative patient, then this patient would have received a neoadjuvant chemotherapy, right? Then this would have been a much more problematic case because she would have responded for a lymphoma part as well, but she would have been suboptimally treated for lymphoma, and she would have had recurrence very early for that. And that with triple negative, both the things would have stayed nearly the same percentages for lymphoma that we saw. Around 50 to 60, it would drop by 10% from breast cancer point of view. Thank you once again.